I've been leading a trial with investigators from around the world of ramucirumab and pembrolizumab together. We started doing this in refractory disease, actually lung cancer, bladder cancer, and gastric cancer. I've reported recently on the arm in lung cancer, refractory disease, where we've seen responses, as you would expect. You see that with pembrolizumab alone, but in PD-L1 high, low, and PD-L1 negative patients. So I think that's quite compelling that we're seeing that. We're also seeing in this group of very heavily pretreated patients, second to fourth line patients, we're seeing a PFS of almost 9 months at the median, which for that refractory lung cancer is quite high. So I think there's something there. It needs to go to a randomized phase 2 or a phase 3 trial. There are theoretical reasons why a VEGF inhibitor might increase T cell proliferation into the immune microenvironment. It might also help with antigen presentation. Well, right now there's so many unmet needs for clinical investigation. We're at the tip of the iceberg in what we understand with immune therapies. They work. 1 out of 5 patients is getting some benefit. Maybe 1 out of 10, 1 out of 15 has that long-term benefit, and is approaching a cure. So we have proof of concept. We know it works, but we have to figure out in a personalized way who it works best in. Many patients have primary resistance, meaning that the tumor doesn't have T cells, so isn't inflamed and won't respond. The tumor might have other checkpoints in play. The tumor might have immune checkpoint or other regulatory mechanisms in play. So we have to figure that out because many patients might need combinations of these drugs frontline. And then we're seeing that many patients, do well, but only for so long, and we don't know how long do we treat. Is there a specific dose that's needed to maintain the treatment? Why do patients become resistant? What happens? How do the tumors evolve? So that's going to become a major area as well. So sensitivity and resistance, I would see as the major area. And then, of course, integrating the immune therapies and this new paradigm into the entire continuum of lung cancer treatment.